Dear colleagues, my name is Thaçi. I'm professor and head at the Institute and Comprehensive Center for Inflammation Medicine at the University of Lübeck in Germany. I'm the lead author behind the paper entitled Safety and Efficacy of bimekizumab through 2 years in patients with moderate to severe plaque psoriasis, longer-term results from the BSURE randomized controlled trial, and the open-label extension from the BBRIGHT trial. The objective of this manuscript is to present efficacy and safety data in psoriasis patients treated with bimekizumab over 2 years compared to adalimumab bimekizumab subject from the BSURE and BBRIGHT open-label extension. At BSURE baseline, patients were randomized 1:1:1 to bimekizumab every 4 weeks, bimekizumab every 4 weeks, and then switch to every 8 weeks, or adalimumab until week 24, and then bimekizumab every 4 weeks. After completing the 56-week BSURE trial, patients could enroll in the BBRIGHT open-label extension and continue receiving bimekizumab. Upon entering the open-label extension and at open-label extension week 24, dose adjustments to bimekizumab Q4 or Q8 occurred based on a patient PASI 90 response. In this report, analyses were based on a patient's initial randomization group, intention to treat ITT population, and for efficacy endpoints, analyses were performed using the modified non-responder imputation, non-responder imputation, and as observed method. In the paper, we report the following efficacy and health reported quality of life outcome: PASI 90, investigator global assessment clear, almost clear, PASI 100, and DLQI 0 or 1. For safety, we report the incidence of the treatment emergent adverse event, serious adverse events, treatment emergent adverse events leading to treatment withdrawal, and the number of safety topics of interest. At week 104, efficacy responses were sustained from those achieved after the first 16 weeks for bimekizumab Q4 and bimekizumab Q4 switch to Q8 patients. Responses were also sustained through week 104 in patients who switched from adalimumab to bimekizumab and were similar to those observed to bimekizumab groups. For the safety data, discontinuation due to the treatment emergent adverse events were low over 2 years and decreased in the second year. Nasopharyngitis, oral candidiasis, and upper respiratory tract infection were the most common treatment emergent adverse event among bimekizumab treated patients across all time periods. Oral candidiasis was predominantly mild or moderate, with exposure-adjusted incidence rate decreasing between the maintenance and open-label extension periods for patients treated with bimekizumab. Looking at the safety topics of interest, elevated liver function test decreased after patients switched from adalimumab to bimekizumab. Apart from fungal events, in particular oral candidiasis, treatment emergent adverse events generally decreased after patients switched. In conclusion, the clinical responses observed over 1 year of bimekizumab treatment were sustained to 2 years, regardless of bimekizumab maintenance dose. Increases in response were also sustained in patients who switched from adalimumab to bimekizumab. Furthermore, no new safety signals were raised during the second year. Thank you for your attention.